on-site or online. Welcome to the first day's course of AEG Taiwan Interventional US Workshop 2024. This morning is the first program, and we have four speakers. And I'm sorry I have to adjust the program because Don also missed his flight yesterday. Now I suppose he will be landing 20 to 30 minutes later. So now we will start the morning course today. I will invite the first speaker, Professor Tawi from Thailand, please. Professor Tawi will talk on the first topic is device of interventional US. Tawi now is a senior consultant of the Roger T. Hospital and also the education program of Thai Endoscope Society. So now we will start his speech with video.
Yes.
Okay. Please play the video.
Oh, we can.
Okay, please.
That's what the person wants for Thai introductions. May I have my slide, please? Yes. This one. The first one, divide. Yes, this one. So, this device. So Professor once already mentioned about the device. I think device is very important for us to succeed in terms of the technique which you use. So I wanted to thank the AEGs for Thai support in terms of education and Mr. Wang and teams, Mr. Chen, the scope, and Mr. Liu's Facebook in the mobility intervention. So as you know, it's not only doctor, not your assistant. Doctor assistant, of course, is very important, and also device. Device also is very important for us. So I give you the first. This audio, the patients present with great leukocyst, and the surgeon make excision of the cyst. Finally, is the pancreatic leak because the surgeon cut at the lower part of the pancreatic portion. You can see it's leak. It's cannot cure, and you can see the PD is a very small one because of the leak. So we can use a small needle, 22G needle, to puncture with good guide wire. We can dilate with a good dilator, and then finally we can dilate because the stricture and leak at the same time, and we can put the second wire, and finally we can put one small stent. So as you know, it's a device not all available in your country. So in your case, you need to adjust. If you start to perform the case, you need to prepare all device, if possible, to make it success. So you can see that even US is apart from the final aspiration, CPN, and then you step up to be the anti-percolation damage, and then USPD, PD, luminal, events, vascular interventions. Today, first of all, a team to prepare all kinds of interventions commonly used in clinical practice. We can separate the device to group. The first group is a multi-device procedure. The second one is a single device procedure. So the one will give you the RA, this is a single device procedure. So in terms of the multi-device, mostly in the interventions we have 6 steps. Number 1, you target the good area. For the BD, you target the identify that. For the wall deposit, target the good location of the wall deposit. Not only the target the good one, you need to keep the good position as well. And number 2, you prepare the needle. Mostly we use 19 gauge needle. Some can be used a 22 gauge needle. Number 3, if needed, maybe contrast. Also BD, PD, you need to indicate the contrast. And then, more importantly, the Y manipulation. And number 5, tactilation. And finally, you put a stent inside. This is the 6 steps in the basic of the multi-device procedure.
No move，
Not move.
不能用这个墨的，这个墨的都没办法。
So let's start with let's start with the first step, the needle. Mostly you use 19 gauge needle. This is a 19 gauge needle. In the market, it's a lot of the 19 gauge needle. Not multi-plane. So depend on the available that you have. The second one is 22 gauge. You need to prepare in case of the small, very small vial. In this case, it's a very small implanted vial. Maybe 22 gauge needle is required. And when you target with the needle, you get contrast. Please remember, when you inject the contrast, you need to fast with the saline to make it more sticky. Otherwise, when you put the wire in, you manipulate really stiff. It's resistance not so good. So you need to put follow with the saline. This is the most important one. Is the wire. I think in the market right now, most of the industry use VCK O25 VCK. That's the most commonly used. So in some part of for example, India, we show you later on, they use O32 Pro this short one. What advantage of Promobile? Promobile is very simply, very easily to manipulate, and the single wire. No one is you can see this wire. It's the 2 part. This the copy one, but the turbo is the single one. This part easily to sharing. That's why some part in India they use turbo wire. Of course, one of the best wire in my feeling is Tonus. I will show you later on. Tonus wire is right now market in Japan. You can see this first video to show you easily to manipulate O25 wire. This show by many days in Hong Kong international life. They use O32 VCK wire. It's very slippery, very slippery. If you use this wire, because it's short wire, not 450, it's only 260. So when you put the wire, you cannot exchange totally. You need to use a 10 mil saline to fast the wire out. That's the technique that you need to learn. And finally, this Tonus wire, this really thin wire. They have O18 and O25. This really good one. Yes. When you spin, it's easily to spin into the line. Sometimes when you put in, for example, this headgear, sometimes when you try to make the wire, not into the center, not into down to the line. Sometimes to the peripheral. If you try to put in and cannot go in, so I recommend to use a rotatable single tone. That's very good. You just follow, you remove the needle, you put the rotatable single tone, go in, the symptom to the peripheral, and then you can spring to the center, and then you succeed AEG Taiwan down to the center area. Step 5 is the dilation. This is also very important. You can use quarterly tip. I think the quarterly tip right now commonly use the 6 pen system, not bigger one, because bigger one make it more leak. So mostly we use a 6 pen system, and you can use a non-dilator. Non-dilator is good one is easy dilator. In my system we use the easy dilator, the main one. But in Japan they use a lens balloon. Of course, Honor also produce. You can see this very thicker and easily to spin. This is the Honor dilator. So we show you this. You can see this when you spin down, you can follow by the cytotone. This is a cytotone. When you setting, normally things intervention use for the setting. We use the pure cut setting. If you use away, auto cut, effect 5, 120. If you use bio 3, you use 3.2. It's compatible one. If you use Olympus, you use pure cut 121. This is a pure setting to cut for the intervention. This we use the EC dilator. This Dr. Pilaku HTS case. And also the final one is this very good one. This we use the toner. This case in my center is a very good provided by our good friend Usahara from the cancer center. Anyway, if symptom is not available, if you see literature by also, so leader night is very dangerous. But for me, if you can use correctly, it's not that very useful. For the leader night, if symptoms are not available, if you fully open the leader night, the direction is the tip of the knife far away, not parallel with the guide one. So if you use the knife, my recommendation, the number one, you open only half of the knife. When you open only half the knife, always parallel. When you open the half, you request your nurse to make a mark. To make sure when the nurse open at the mark, only half. The second one, you blend. Some doctor to blend. To blend them. When you pull it open and you blend. When you blend, it's always parallel. So if cytotome is not available, it's my personal view, the knife still really benefit. But you need to understand how to modify the device that you have. When you put the wire in, you take dilation. In some particular situation, you need to put the second wire, especially when you insert the plastic stent. Because plastic stent, when you insert it, if you fail, you fail everything. So second wire is really important. So many devices that you can put one. This double lumen catheter. Right now in Thailand also not available, however in Japan. But in Thailand available, this one is good one. This is a harbor lamp. I think so, you make a more familiar with harbor lamp. And also this really good one. This concept by Professor Topalon. This bus cycle. This bus cycle by Boston. The first one you can insert over the bus cycle, and then you cut the bus cycle out. When you cut the bus cycle out, when you insert the bus cycle in the diabetic pipe, and then you remove the stylet, and put the second wire. It's really good device. I commonly use when I decided to put the two wire, especially in case of the HTS with the plastic stent. So this case you can see. This is the first wire in, and the bus cycle follow bus cycle, and then we remove the stylet and we can insert the second one. That's very, very good. So some case, maybe you need to dilate. Very limited case. If you need to dilate, please use small balloon dilator. Mostly we use a 4 mm, not too big. Because one of the multi step, the problem is the leakage. So you need to try to minimize the leak. And finally, you put a stent. Depending on the case that you plan to put in. Right now, so for metal stent, a lot of the metal stent. For plastic stent, I recommend this very good one. This IT stent by Pacific. Also, not, I think it's available in Taiwan, right? But not available in our country. I use this one. This is also good. This we call the reposition stent. What the meaning? Small thread to fix the stent and puncture. So when you put the wire in, you put stent in. If you cannot succeed, in, for example, when you put the stent in, to find some friction, you cannot pass stent in. You still can remove. You can still remove stent and keep the wire. This we call reposition. In the market right now, there are two companies. The first one is Navitec by Boston. In Thailand, we also have the one from the Liubeck in China, friend, the same one. In this case, is this Dolo ankylostommy. You can see it. I use this stent to put in. Yeah, this very good one. Finally, is a stent. So I think stent depends on the case that you can use this geocore stent for AEG in malignant. And right now in my center we have more case in benign ATS. So normally we use a really small one, 5.9. This is a benefit copper stent by in my tech. So this is really good one because when mostly we put puncture, injection, follow the saline, wire, and then dilator, and then follow with the stent because it's a very thin one. Before that is the stent, the polycopper stent is 8 or 8.5 is too big. Maybe you need more dilation. But then now is the listing system is easily to go. And for the single device, procedure, bone, CDA, provider, etc. We can divide it into two groups. The first group is endoscopic control device. In the market right now, we have the two devices. Number one is a hot axle when you use it. Right now on the market also we have the hot palmer or is IT9. This by analog magnetic. And second one is acid control device. That's your assistant to control the assistant. This SPECSA, the hot SPECSA. What different? Different because the endoscopic control device normally we have a four step. I will give you more detail later on. But assistant control device is the same when you deploy in the BD stent. The technique is the same. But nurse and the suite need to understand the marker how to deploy the stent. For the endoscopic control device, you need to understand because some confusing in terms of the setup. What it means setup? The setup means the length of the stent. For the hot axial, they mostly have the 1 cm, and only one this size 15 and 15 cm. Mostly they have a 6 mm diameter, 10. But the palmer is different. The palmer, if you have the 2 cm, when you request 2 cm, the length is not 2 cm. The length 12 mm. You can see this one. This commonly used. They use the 16 diameter of the stent. the length 2 cm, but the saddle only 12, not 2 cm. So you need to understand the divider you have. Okay. Okay. Number 2, you need to understand we call the land weight. The land weight, what the meaning of land weight? The land weight, when you deploy the first span, you need the length to deploy. That's very important. For a half axle, if you use a 6 mm SF long, the land weight is 2 cm. If you use a 10, the land weight 24. For example, EJ you use 20, the land weight is 4 to 4 cm. That means, what that means? That means when you puncture with the hot axial, you need to put catheter down around 4 cm. If you put the catheter shorter than 4 cm, for example, you put the catheter 2.5 cm, what happens? When you deploy the first stand not into the target, the outside the target. So you need to understand the land weight. Different design, different land weight. So you need important to understand this one. And this I summarize the same design that we commonly use in each particular procedure. And this is a 4-step for the endoscopic control device to identify the target, and we give you more detail later on for the this one. And this the hot axial for necrosis is a 4-step. Your indentation, you put the pot inside, you keep the foot land weight, and then you deploy the first span, and then you pull back to snap the wall, and you deploy the second span. This is a technique for the endoscopic control. You can see it open the first span, and you pull back, and then you deploy the second span. So I think in the workshop tomorrow you can learn how to deploy this device. For the second one, this hot plumber. The whole technique, but a little bit different in terms of the you can see it. First one, puncture, keep, put land weight. You lock and then spring to open the first span. Yeah, you open the first span until the sound click, and then you step 3, you pull back to snap them. So all the device, you and your assistant need to understand how to deploy the device properly. Very important. You need to learn together. And some intervention, not only the device that we have, maybe we have alternative. Alternative means that you give more device. For example, this is US guided gastroenterostomy. So it's e-pass is a very good one, I would say, but not viable. You may modify with the aortic balloon. This is aortic balloon. You see, these are commonly used in our center. We use both aortic balloon to fit, to make this dilatation, central dilatation by that, and easily to make US guided TK. So you need to learn the technique that make the safe and efficient for the US guided. So I think device is very important. You need to understand what device you have, and then the technique to learn with your assistant. Thank you very much.
Howie, very good explanation of the important device. Is there any question from the audience? Yeah, please raise your question.
I think Japan, Korea really good device, but limited. And outside Japan is still limited.
Yeah.
Yes.
I want to ask about the guide wire. You mentioned the 0.032.
Yes.
How does it compare with the 0.035 then? That's very.
So normally use guided is this guide good one. This guide O25. Why? The number one O25 smaller than O35. If you use smaller one, you have more room in the needle to spin. The second, you need to stick one. O25 you stick one. Stick wire very important to keep the tag. That's why this guide tool is very good because small one and stick one. If you use OT5, it's a little too big, difficult to manipulate. But to normal wire, they use normal O25, OT2. If you use OT5 to normal wire, too big. But if you use O25, too small. That's why in India they use O32 because it's a proper one. It's a stiff enough and easily to manipulate. So in my case, is that if I fail in terms of the whole VBC guide, I also use to remove my OT. If you have explained in ESP RCP, ESP in my center is in difficult case we always use to remove my.
Any other question?
Recording in progress.
I will ask question. Maybe later someone will ask. How you choose the just now MITech stand fully covered? How about the lens and how about the blockage of the other branch if you apply it on HGS?
You mean the hot plumber, right?
Yeah, no problem.
Hot
I
plumber.
might take the benefits.
Or benefit. I love it. The what benefit is 5.9 when depositing. Very thin. In my center, in my center is a Pantopili center. We have a lot of case hepatitis here. If you know it's a hepatitis here is very difficult because mostly the surgeon make a long wide. So we have a lot of case, especially post-parentally, they get head case here. So in this particular situation, the bite not too big, very small one. So that's why when I use the HES, we approach by anesthetic, not right now. Mostly we approach by just guided, not enteral in RCP. And then because of benign condition, that's why we decided to use fully covered. I don't like part extend. I use some case, but I don't like. Why? If you part extend, 4 months later on, you need to exchange. Very difficult to exchange. If you use the Hanolo, is a very big stem. We use a small one, 8 mm. 4 weeks later on, we can exchange, we can remove, and the track is really big one. So easily to cannulate. I cannulate down to the HJ here, we dilate and push them in. That's why I love to use it because easily to put very small. Mostly we do not use, right now we do not use the cytotone. We just use an easy dilator and followed by stent. Easily to put.
Any other question? Okay, if no, we have to move to the next
This one.
next topic.
So the next one is USPD. I think think when you familiar with the warm negotiation, and then I think the second, the follow one is BD is commonly used in a lot of cases. Yes, sir. So I give you the background of the SPD, treatment strategy, procedure design, and also, as you know, the SPD is three categories. The number one is the direct time role. Direct time role is critical nosomy, hepatico, gasotomy, and or even hepatico-nosomy. This time role to push them from the luminal into the bile. The second one is the indicate. Indicate means you use especially the pancreatic to assess and then push them in the normal and we call it this indicate. The third one is long loop. Long loop you use guided to negotiate the guideline down to the normal anatomy and you change from the use to the ESP scope. That's the three categories. I think the ESPD is mostly a very good available for the religion and asset when you fail ESP or selected case, especially in the serious at the first line. Why? Because you can see this recent publication, they summarize this ORCT. They summarize to compare USPD, the first line, and ESP for the distal bilateral. You can see in terms of the success and technical success is not much different. And also the good for the PD in terms of less intervention. And especially zero pancreatitis. And you know ESP you have some small percentage of the pancreatitis from mild to severe. But USPD is zero percent because you do not touch the ampulla and the PD. That's why maybe USPD, if you selected the good one, is the good primary. So number two is the location, the HES, CDS. You need to probably depend on the location of the tumor and the nature of the origin, benign or malignant. Generally, for the CDS, we use a tubular stent, and you can select lamp. And we will give you later on. In my center, we really carefully selected indication for use the lamp. For ATS, depend on the benign or malignant. For the malignant, mostly we use a pure stent by the EMU. And benign, mostly we use a benefit already mentioned about, and also sometimes we use the pathogen in case of the really small bite. So the technique mostly is a multi-stage technique. So you and your assistant need to learn together, need to work really well together. That's the key. That's really important. Not only yourself, but your assistant is really, really important. And of course, if you the patient more than happy if you have surgeon, especially intervention is to back up your procedure. If you fail, sometimes create a cholangitis, so interventionist will help you and help the patient as well. So already mentioned about the UPD is 6 step. This multi-step device. The 6 step identify the target bile, check the Doppler, put the needle in, to make a plagiogram, to clean up with the saline, wire preparation, degradation, and stent placement. But for indicate, you need to manipulate the guidewire down to the adrenal to port secure, and you need to dilate before you put stent in. Otherwise, some friction, and you cannot pass stent. For For the long loop, of course, you need to change the scope. A device for dimensions, this is a device there. So, what tip? Let me start with the CDF. The CDF, this is the scheme to show the CDF. CDF, you find the elevation by the put it in contact, vibration, saturation, stent. I will give you step by step. So this the standard technique. You give the rotation by that put stent in. What the trick? Number one. CDF, your tip scope in the lunar bound. You need to see the follow with this picture. This really stable picture, really stable scope. And your scope tip to the highline. You can see your scope tip to the highline. And you keep the viaduct very close to the probe. You can see this pen, this very thin, this very thick. What the meaning very thick? Very thick, that means double puncture. So be careful, double puncture. So when you see this one, you need to try to manipulate. Put the water in to make it not too big one. Just make it. Normally it's the probe and the viaduct, mostly 5 mm. Mostly 5 mm, not more than 5 mm. So be careful, double puncture, and be careful the bleeding. So you need to check the Doppler before you puncture this bleeding. When you check Doppler, you need to rotate clockwise and counterclockwise. Why? Because when you put the Doppler negative, when you put it in, bleeding, especially when you burn. Why? Because the small vessel close to the puncture site. So I recommend when you see the Doppler negative, you rotate a little bit. Okay, Doppler negative, you come back and rotate to make sure allow the puncture site is no vessel in between. That's very important. And then you inject contrast, and then you put the wire in. The trick, you need to put the wire in the integrity pipe. Be careful to put the wire in the compactor. Really be careful. So you need to make sure your guide wire up to the integrity pipe. That means craniogram should be good to see integrity pipe. That's really important. And then you maybe you use quarterly or non-quarterly, and then insert the stent in properly. When you insert stent, please keep the upper of the stent below the highline, not entirely. Because if you put entirely, what happens? You may obstruction the sidebar, make it pancreatitis. So keep the upper one below the highline, and the lower one, try to put the lower one to the anal side, not to the oral side. If you put oral side, maybe tomorrow, the day after tomorrow, the patient got pancreatitis because the food coming and block and pancreatitis. So the distal one, try to put to the anal side. Lamp. In Western, if you see the literature, they more prevalent to use a lamp for the CDS. I personally don't like. Why? If you see the lot of the cohort study or even RCT, I think the technical success CDS with the lamp and tubular is not different. But adverse event, especially some syndrome. For tubular stent is a very few case of symptom if you put the stent down. Very few. But for the use of lamp, easily to clear some syndrome. You can see the percentage from 2.5 to 10 of the some syndrome. because you create sedate with the lamp, same the surgeon create critical colostomy. That was open easily. How to minimize this particular adverse event? You use small lamp. So right now, for safe, we recommend 6 to 8 millimeter diameter, small one. Or some doctor put the pigtail inside to minimize the water. I personally use the lamp in 3 categories. Number one, aseptic. In some cases, we require to put serious. The second one is high puncture. In some cases, no space, it's a limited space with high puncture. If high puncture, if I use the stain, is definitely the upper side of my stain is blocked into the interpreting. And in particular case, I use that. The third one, I need to intraductal treatment. If I need to intraductal treatment, for example, benign case, sometimes we use the lamp in benign case, and then push by to little gypsy, I use the lamp. So this the technique to use the hot axial. This is 8 I think that is 8 millimeter. Put in, keep the lamp weight. Please remember, keep the lamp weight, and then slowly pull it open. The first plank, and then pull back, and then deploy the second plank. So CDF with the lamp, the diameter of the spider, very important. Very important. Please remember the lamp weight. You can see if you use 6, the lamp weight 20. If the bite smaller than 20 millimeter, difficult. But if require lamp incident, if the bite smaller than millimeter, recommend use Taiwan. You put Taiwan first, and you follow the lamp with the wire. That is get more the lamp weight. I will give you this adverse event. They use Taiwan, you see. But the problem, they rapidly insert the lamp. If you rapidly insert the lamp burn the bottom end. It's a massive bleeding after use the lamp. This report in the SOP. So be careful. So when you use the lamp, you keep the number one, you keep the peel cut setting. Indentation. What does mean indentation? Indentation means when you put the catheter to make sure the target area is compressed, and you slowly burn. You keep slowly burn, and then slowly insert the catheter. Not force. If you force, be careful, complicated. For the head, yes, the same technique. This technique to it, yes, this is a malignant. I use the gel ball. But number one, what is it? Number one. Number one, mostly right now, all the space recommend to puncture the BT. Why? Because B2 is sometimes really close to the effusion or even esophageal action. Number two, the needle direction, very important. You need to keep the needle direction to the central. And you see the viaduct here, you can see the viaduct here, this is a B3. You can see the viaduct here, the needle direction is going to the central, not to the peripheral. If to the peripheral, it's sometimes difficult to manipulate the guide wire. Why? This one authentically case report by Mr. Hawan. This the puncture, and then the patient clear severe meningitis later on. You can see because of the time esophageal puncture. So if you see the endoscopic view to get the puncture, if not sure is the time or not. So Mr. Hala recommend to put one clip in the deep section. And you can see on the photo, on the puncture site to make sure your puncture site below the tip, to make sure your puncture site in the gastric area, not esophageal. So when you puncture, in some case, you need to puncture beyond the bile duct, as a rheumatist to make it. And then you slowly pull back. Go beyond and slowly pull back to see the tip. You need to magnify to see the tip in the bile duct. This is more difficult. Compared with the HTS, it's more difficult than CDS. Sometimes this Dr. Kirat make it this maybe last 2 weeks in Upper Hospital. In some cases, this is HTS very small bile duct and allopecia, very difficult. So Dr. Kirat to puncture with the 22G needle first, and put the contact and saline to make a bigger one. The first one we try with the Taiwan, but not succeed. So because we get the bigger one, and then we change from the 22 to 19 kg, and you succeed puncture. In some case, you can make it small, the bile duct more bigger. So this good one, you need to understand. If you inject the contact, if the cholangiogam, the contact still remains. If you puncture, the contact rapidly gone. That means you put the needle in the portal vein. So be careful. So please remember, when you inject contact, the contact should remain. That means it's bile duct. If rapidly gone in the portal vein, you need to readjust the needle puncture. This is also very important for the HTS. This is by Ocula. This we call liver infection. So sometimes difficult to manipulate guide through the central. So the trick, you just pull back the needle into the liver and then easy to rotation to avoid the shearing. Because sometimes when you manipulate, especially the small duct, the wire may be shearing at the needle tip. How to avoid that? So pull back the needle into the liver, and then try to manipulate the guide wire into the central. This is really, really good technique. You need to learn the technique how to manipulate the guide wire go down. I already mentioned about to change the direction. So the step 5 is the dilatation. If you have a good dilator, it's a very good one. And then mostly right now for HF, we recommend to interchannel deployment. What the meaning? The meaning interchannel deployments we deploy stent inside the channel. That means to make sure you stand in the gastric site, and then you push into the gastric. Why? Before that, if you deploy under vision, same when you perform ERCP, you need to back scope, right? You need to go back scope, and you need to put the stent in. When you put the stent in, you put back scope. The problem is the liver and gastric site is separate. If the liver and gastric separate, easily the stent go into the interpitally. So HTS mostly recommend interchannel deployment. And when you deploy, and you nearly deploy, you put the stent down. If you encounter the stent into the esophagitis, you need to rearrange the tip down into the gastric site. Otherwise, maybe create big complication. It's very important to keep the tip of the end of stent in the gastric site. So some case maybe you require hepaticodonostomy. This hepaticodonostomy. Same because the scope into the bowel and target to the deleted area and 5, 6 steps, same. No one different. We show you the test. This is a sticker. This is a dual bound. We puncture and we check the contrast because that's a benign condition. And we use a cytotome to dilate and we use a stent. This case also use a benefit stent. This some case may be possible. But this case be careful in terms of the segmental obstruction for polycapillary. In some case we use a plastic stent. So for indicate, I think indicate maybe the same one. For the tip indicate, you need to manipulate the guide wire down. This is the key part. When you burn, you put device to manipulate guide wire down to the and you inject contrast to see sticker area and you dilate. You need to dilate. If you know dilate, mostly it's difficult. A lot of distance, difficult to put the stent down. So normally we use a hurricane balloon to dilate sticker side. And then you decided the stent that we have, mostly the malignant, you can use a copper or uncopper stent. And to technique, if the high one, you can put intraductal stent placement, or you can put a transcatheter. I think depend on the location of the tumor. So the trick, if you put a transcatheter, my recommendation, I always keep 3 cm in the dural side. Why? Because if you keep shorter one, I encounter one case of the end of stent penetrate contact the water and for the breathing. So I always put the end of the dural side down 3 cm to make sure it's put parallel with the lumen. So the other one is the competitor technique. Competitor is I think the technique same when you perform in the wall or necrosis, the 5 step. So this is an indication. So what the trick? So normally I use hot lamp and I use only 10 millimeter, not too big, not too small one, and only 1 cm. So mostly in my center, very strict indication. So I do it only never surgery at Taiwan to describe this term. That means never surgery. So people to not pancreatic, because pancreatic may create a problem in terms of the food infection, stent migration. So pancreatic may be used it, not sure for further surgery, maybe for temporary. So if you use pancreatic, recommend to use the 7 French 5 cm double pigtail to inside. I encountered one case of the stent migration. So, but we can still to see the plastic stent, we can remove the embedded or burly of the lamp. So in my summary, SPD is a valuable technique. So I think you need to learn step by step, especially you and your team, your assistant. Of course, if you just start, you need to inform your colleague, surgeon, interventionist. A lot of trick. If you start, more than happy if your senior doctor, more experienced, stand behind you. So tomorrow you can learn a lot of technique by yourself. And also you can enjoy this our YouTube channel is my unit. You can see all interventions. And if you enjoy and you visit APW this year in Bali, we also have the US course. So, thank you very much.
Thanks, Howie, very great educator in the world. Any question for his talk? Yeah, please.
When you burn into the awful thing, you saw the blood coming out, what kind of pain will you do?
Not my case.
How did you manage?
Fortunately, it's not my case. In this case, how they fix it. So they burn, they pull back, and they put the lamp. When you put the lamp, they manipulate the guide wire down to the papilla, like along the wall. And then you chain, they chain each guided to ear speed, and then they put the fully copper to compress the portal weight. That report in the endoscopy.
We done very
Yeah, that when they compress the fully copper stent is and compress and stop beating. I think in this case maybe fortunately and it's not really thick. Otherwise it's very difficult.
Other question?
Is
Thank you for a good lecture. In cases of AEGS, after successful placement of anterior stenting, do you usually place another stent for keep the AEGS fistula or cancelling the bile leakage or not?
I think it's all a very good question. Two ideas. Some doctors keep one plastic stent. Some doctors do not. Just remove. Because of the good drainage. When you good drainage, intestinal bile ducts are very low pressure. It's no problem. So I have two ideas. If you're not sure, maybe use one plastic stent to keep. So you can do both. So in experience, these two both ideas no any complication. In my center, when I put the pedicle stent, I remove everything. I do not put plastic stent.
Okay.
What about the first one?
Yeah, we usually put another one
Another one.
because we have IT system.
They have plastic stent. Just some put the plastic stent, not the metal stent. Just put the plastic stent. So, but in my center, normally I remove. No any problem. Because if you put drainage, it's the interductal pressure is very small and it keeps it back.
I have some question about SGS. If the stent was incidentally pressed in the esophagus, how to rearrange the tip of stent into the stomach?
Thank you, this question. Normally I use the small Pepsi faucet, capillary stent, small one. Please do not use the left tool. They use a small Pepsi faucet at the end and put down easily. Just keep small at the tip of the stent and then you put down. Please do not use lateral faucet. Why? Because when you use lateral faucet, when you put in, difficult to remove. Very difficult. Please use small orthopedic faucet.
Can you explain your technique as request? You can deploy in scope and put the scope over, that's right?
Yes.
And
Yes. Normally it's my recommendation when you put interductal channel, you interchannel deployment, right? When you keep interchannel deployment at the end, you put down. You put down. Do not pull back all the time. If you pull back all the time, always in the esophagus. At the end, you put the stent down into the gastric side. Not pull back, always in the esophagus.
other question?
For distal, for malignant distal bile structure, compare with the US anti-grade stenting and the US HGS, which one is better? Do you think?
What the problem?
For malignant distal bile structure.
Malignant distal bile.
Yeah.
Yes.
For compare with the US anti-grade stenting with HGS, which one is better?
So in the distal bile duct tumor, right? In my center, distal bile duct tumor, we decided the transluminal or transhepatic. Depend on the if narrowing is a big tumor, I use transhepatic. If I use transhepatic, I use HGS. If small tumor, no use CDS. Yeah. I use pan indicate only the tumor in the mid portion. If the tumor in the mid portion, I use indicate stenting.
Basically, in some of our CDS software CCD, we actually deploy labs. I found there was quite a few cases where we had a food infection. So how do you minimize? I know you don't quite like lamps in CDS, but is there any tips or tricks that you can do to try to minimize?
Typically, to minimize the protection is some syndrome. Is number one is small, use small one, 6 mm or 8 mm diameter. The second one, you put the plastic stent inside. One 7 frame, 5 cm. I don't like 10 frame. I think the 10 frame is very cumbersome. So I always use the 7 frame. So the two technique to minimize small diameter and one plastic stent.
Thank you very much for a very good lecture. First question is when you deploy the AGS stent, how much do you put of the stent inside the liver and how much you keep outside deploying the channel? Second question, when you integrate stent deployment transpapillary, do you prefer 4 mm or 6 mm dilation before you place the stent?
Thank you. The question number one, I use Japanese style. The Japanese style, they keep getting side 3 to 5 cm. So normally in the liver side, allow 5 to 7. So in my center, normally we use 12 cm. I keep maybe 6, 7 inside the divider and 5 cm in the gastric side. In some case, I use 10 cm. So in Thailand, I go 10 and 12 cm. So answer to the question is we use a long one. But in European or even in US, sometimes they use short one, 1, 2 cm. So in my personal view, if you use short one, be careful in terms of the intra-peritoneal deployment. It's very, very big. I think the long one is safer. The second question is for the indicate. We always dilate. Because the stent is a small one, we use it only for 6 mm, not too big. To make it sure easily to insert the stent, that enough.
I think time is limited, unfortunately. I think there's a lot of questions for you, but we can discuss later. There are 2 questions online. Please answer online.
Yes.
Okay.
Yes.
Okay. Thank you very much.
Yes, thank you very much.
So, Professor Dong also just landed, so he's on the way here. But I request Dr. Ho to present his topic in advance. So he will talk on the GJ, and he's my colleague in my university, and he's very famous for intervention in the US, including the GJ in Asia. So he has a country experience, I think so. So please start yours.
Thank you, Professor Kurosawa, my mentors, kind introduction, and good morning, everyone. Welcome to your coming again. So, just following Professor Tawi's talk, I just wondering to share USGJ, especially the USGJ is off-label use until now. So I just sharing our experience and current evidence how far the rules of USGJ in current conditions. So we have downloaded the file. today's talk. I just wondering to sharing tips and the tricks and how to share our experience how to successful to playing GJ. Okay, so mostly use GJ is currently for gluteal obstruction. So the ideally is from this part, and the most American gluteal obstruction is caused by pancreatic cancer. So as you know, the eating is very important because it's the most life quality. And another way is the gluteal obstruction. Some patients need to have some decompression, loss of quality, and also will cause malnutrition. So in so no, in this United States, the cohort they already find a lot. Pancreatic cancer have poor prognosis compared to other cancers, just like the sugar this way. Okay, so but if no matter pancreatic cancer or non-pancreatic cancer, if they presented with gluteal obstruction, their survival just only around 3 months. So no matter which kind of cancer, so it means the gluteal obstruction is a poor survival factors. So I think it's most patients caused due to malnutrition. So now we should think about, because in the past we always waiting the patient already total obstruction and we start to evolve. But I think maybe now patients have a symptom, we should start to evolve to relieve the gluteal obstruction. So back to in the past, two major methods, surgical bypass and enteral stenting. So I think most of you already know that surgical bypass can have a longer patency, but the most disadvantage is the longest recovery day and the longest hospital days and higher mobility rate. How about endoscopic stenting? I think it's also endoscopic that you have a lot of experience, so you know it's quite low risk and very short times of recovery, and for patients very good. But the major problems like this one, you can see not only the tumor ingrowth or tissue overgrowth will shorten their patency rate. So it is a very big, huge cohort. They find a lot the enteral stenting and the gluteal bypass. They find the survival if the patient can receive the surgical bypass. They find the survival is better than enteral stenting. This is the intake quality and the nutrition is better than enteral stenting. If the patient, because these are retrospective data, just only select can receive the surgery. So in the AEG guideline, I already mentioned that if the patient, if life quality is more, life expectancy is more than 2 months, maybe surgical bypass is better than enteral stenting. Okay, so that if they cannot do that, laparoscopic approach is better. If the patient cannot receive surgery, enteral stenting, or use GJ may be another choice. But you can see that it's 2021. So in recent 3 years, more and more evidence of use GJ, because we know that more and more patients can survive longer, more than three months. So maybe USGJ is a chance because it's a minimal invasive, and also like a surgical bypass have a long-term patency rate. So let's back to USGJ's history. Actually, in 2002, some doctors have ideas want to perform this kind procedures in an animal model, but at that time very complicated, a lot of dedicated device. So just only can apply it in animal, not actually in a human. Fortunately, in 2007, Professor Bimorers, they designed now we know that very well is the high issues. They can just very easier to puncture in and deploy the stent and connect the two hollow organs. So at a lot of times, so in 2012, they start to did in the animal study, and they find is good feasible way to perform USGJ. And 1 year later, Ido Sensei also divide this e-pass to endoscopic double fluorescence device and combined with luminal pulsing stent. At that time, they used maybe original spatial stent. So, and 2 years later, this publication, the first human studies in USA, is from Professor Barron. So he used 10 patients, very safety and efficacy to successful complete this USGJ. And also 1 year later, also Ido Sensei also used the e-pass to perform 20%. And you can see the technique success rate is quite high, it's 90%. And the procedure time is very short. So at a lot of time, you can see such a department, the US gastroenterostomy, the gradually growing. So now accumulate more and more evidence. So now we think the USGJ becomes the one option. So this is our first cases we did in our unit. This is a very big gallbladder tumor. And at that time, we don't have the experience of the USGJ, so we think maybe it's a good candidate because if we are already stage 4, not suitable for surgery. So we think if we want to press a jejunal stent, maybe we need to press 2 or 3 more stents. Maybe the efficacy is not so good. So back to his patient, for him, maybe you can consider the 3 types. So I just want to emphasize some any evidence between the understanding and the USGJ. So mostly is retrospective data, but recently we have a one randomized control trial. So for this, mostly is for this retrospective data, you can see that the clinical success rate, USGE, significantly in 3 studies is higher than understanding. And the technique success rate is almost similar. But if we look the adverse event and the hospital day is very similar. So it's like it's all the same endoscopy procedure. So if from experienced endoscopist to perform USGE, you can very with an acceptable complication rate to perform USGE. I think the most important part is the intervention rate. Intervention rate, USGJ, just like the surgical bypass, they can cause a low intervention and the longest patency rate. How about the USGE with surgical GJ? So also, I just summary some already reported data. I think most of this data is retrospective data. And you can see the most large sample size is last year. I think no matter technique and the clinical success rate, two methods is very similar. But if you look at the adverse event, USGE is better than surgical bypass. I think because it's endoscopy, another is surgery. I think the intervention rate is quite similar. Some data shows favor USGJ, some data favors laparoscopic GJ, but all is from retrospective data. So just make a very quick summary. This is last year's meta-analysis to include all these data. They show that many summary USGE have a low risk of recurrent obstruction and compared to endoscopy standing, and also have a fewer adverse events compared to surgical bypass. So following these years, I think most of you already know that it's a randomized control trial by Professor Anthony. They just comparing entostem and USGJ and show that you can see this curve. It's almost no reintervention rate in the USG group. They can decrease almost 85% reintervention rate. So not only reintervention rate, for life quality, this is a questionnaire prospective data, also can offer very good qualities of life. So I think maybe in a few years later, USGE will become one alternative treatment modalities for the malignant ganglia obstruction. So just very short summary, they just combine the surgical advantage and the endoscope standing advantage. I think this is USGE. So let's talk about the technique part. I just summary the technique part of USGE have three types. The one is the most application used is EPAS. It's a two-balloon occluded endoscopic bypass. And the second one is some paper also mentioned. It's just put like the CRE balloon, or we use the balloon dilatation balloon for the target, and you puncture that way. It's called balloon-assisted gastroenterostomy. And the third one is now in our unit we use is direct GE punctures. For this method we use two different kinds. The method is over the wire. This means you use a testing needle to puncture the bowel and then press the guide wire and exchange lengths to put the lengths. Another one is direct punctures without wire. We call it the wireless technique. So let's talk this. I already mentioned that EPAS. So EPAS is just like this one. They need to like you put the guide wire and you need to put the over tube. So you should put the guide wire first, and then you need to remove the scope and insert the over tube. So it's very, this is over tube. So you should two-step. You put a guide wire first and put another over tube. And this is a marker. And then you can inflate two balloon to occlude. So it's because I never have this kind of experience, so I cannot have any comment, but I can just see some video from and some lectures from Ito Sensei. So just like this one, so it's quite bigger. So I think that sometimes we'll encounter some problem if the very tight structure. So just like this one, and you inflate two very big balloon. And then you inject the contrast here, and you puncture from stomach to here. And I think the most advantage for this method, you can inject very huge saline to inflate our target bowel. So in the recently from Canada, Dr. Chen, they modifies the EPAS balloon, just like this one. So I cannot play. Maybe this video cannot play. Okay, that's okay. So I just described. This is not like the EPAS. They can through a scope. It's very thin. It's very thin, but it's also very too big balloon. So not like the original Ito Sensei's EPAS. They can just through a looking channel, just put a guide wire and put this one, and then they can change this connector, and this connector can inflate to two balloon. So it becomes more easier, and they can also just like. Okay, so their study also did very good result for this pilot study. Very like the it always says the EPAS burr, but they can just more convenient. So we are also very looking forward to this product in the near future. Another one is the freehand technique. So freehand technique, I just already mentioned, is two methods, over the wire and the wire slice technique. So in this study, they will suggest use the wireless technique. Because while you put the guide wire, and if you use lamps to shoot a guide wire, sometimes if you puncture it, you will let your guide wire to pull out. So will cause a higher adverse event. So you can see that. In the over wire, this group have more than 30% adverse event compared to wireless technique. So if you don't have the EPAS and you are already very familiar with the lamps, I think the wireless technique is maybe it's better. So another study also comparing the red puncture wireless technique versus burn assisted. So they also show that the similar technique and the success rate and the adverse event is similar, but use the red puncture is time saving, it's a shorter procedure time. So very quick summary, if you don't have the EPAS, maybe the red puncture with the wireless technique, maybe it's better. Okay, so I just show you how to perform the red puncture with wireless technique. Just like to put the enter stand, we use the scope into the obstruction side, and then we press the guide wire, and then we press the oral entry tube. And this tube we will connect to infusion pump to can infusion the saline, and then we use the US scope to press the lamps. Okay, so this is our unit's protocol. So the first one I need to mention that every cases we will use intubation, because you know we inject the saline to protect airway to avoid aspiration pneumonia. And another point is you should prepare glucagon, because the red puncture not like double balloon occlusion. So you should avoid the bowel movement. And this is one method to can inflate your bowel as large as possible. So another one is we will connect the irrigation pump, and our flow rate is adjust to high rate. It's 500 millimeter per minute. And usually initially, if you don't have the experience, you can use a fine testing needle to puncture your target, because our saline will mix with indigo carmine, like the blue light. So if you don't have confidence, you cannot recognize this is a bar, small bar, or large bar, or column. You can use a testing needle to puncture and suction a little fluid to confirm. Okay, so I move to our how to I did. Okay, so the first you can just depends on your endoscope. If you for type 1 geo, maybe for you is better. So it depends on just like your understanding. The first step is very like understanding. You just try to put your guide wire into the proximal jejunum. So here I just mentioned that I like use the A-type balloon, because A-type is above balloon, because you can include the balloon and inject the contrast or some air to inflate your distal bar. And now I like use the angle tip 0.5 guide wire, easier to cannulation. And then I think the most important part, most exploratory discussion, which part should we place our oral entry tube in which place? So I think it just depends on which part you want to puncture. So usually I will prefer put our oral entry tube in the more proximal jejunum, because they can influence the saline into a distal part, and this is the better. Okay, so then then press the oral entry tube, then we can infusion, just like because we don't have a double balloon. So you should try to inflate your ball more direct, more inflate. Because just like balloon, if you inflate very large, you can very easier to puncture. If you did not inflate very big, maybe very easier to did not puncture. Okay. So the step 3, you should choose which kinds of ball should we puncture. This Professor Tawi already mentioned. We should thinking about you put the size, you put the distal flange, because the distal flange need some distance. So mostly now we use 20 millimeters height, so more than 4.8, some space is better. So if possible, I think this is more safe because they have more distance to deploy this distal flange. So, but not always you can find this kinds of tacky ball shape. So just for example, for this limb, so we can puncturing, and puncturing you should check your tip very carefully because it's very important. So usually I will put in most deeply part and then slowly deploy your distal flange, because you can see you need a lot of space to deploy this stem. But not always. So for example, sometimes you can only approach to this kind ball. So you can puncture in first and like just adjust your big wheel, then let your needle can dig more deeply, and then deploy your stem. It's becoming more safe. I think if possible, you should not choose this one's shape of a ball to puncturing. I show one case is our troubleshooting cases, because like this ball you did not actually you put in, but you don't have any spaces to deploy your distal flange. So in this kind of situation, you will very easier to let your stem to outside the ball. Okay, so if possible, try to find better shape of your ball, not like this one. So because you know the stem displacement stem is the most adverse event, most common. So in especially type 1. So for that patient, just also is a type 1. For type 1 stent displacement, I think it's can solved by endoscopy. So we also want to show in one case we ever encountered. This is also is gastral obstruction, and because we did not confirm our tips of the stem, so okay, the first because I cannot adjust the. Okay, so now we press the oral entry tube and exchange to EUS scope, and then we inject the contrast. I just want to show that while you're puncturing, you should be very careful with your tip. So in these cases, okay, so we try to find the puncturing site. Okay, so initially we think we already inside in the ball, but you should be very careful. Actually, this patient, we did not real punch through the ball. We call that the tender-like sign. Actually, you just contact the tacky ball. So at this moment, if you deploy your stem, actually your stance is in the peritoneum. And another sign, you did not see any fluid flow out from this stem. So this is the evidence. For this case, if you want to confirm, you can use the balloon to inject the contrast, and this is in the peritoneum. So if you encounter this situation, you don't be very worried. You just take it out very as soon as possible, and use your short clip to close. I think the stomach is quite have a strong muscle, so it's quite safe. So you can just close. And for this case, we did the sensations USGE at the same time. So this time, we just very careful to observe your tip. And always I will suggest you to and fro to confirm your tip real in the bowel before the stent deployment. Okay, this is a very important point. And this is like usually if you deploy very successful, very bullish fluid flow out. Okay. And sometimes we always cannot know what will happen for UHJ because this lamp sometimes will something happen. For this case, we also encounter some not like troubleshooting, just like the stent did not deploy full expansion. So the previous step is almost similar. So, but I cannot skip. So, sorry. So this is we like to prefer the stent shape. So it's very good good distance. So in this part we think we already can finish very quickly. But after deployed, we find something wrong. You can find out the proximal lens did not float. So the company guys told us maybe the membranes have sticky together. So we are worried about it's not full expansion will cause the stent internal migration. So at a lot of times we just use a balloon, repeat it to dilate it for this stent. It's just like this one. So while you pull out your stent, you should be very careful. I think in this case is better, but another cases is more, I think, more shock us at a lot of times. So we can see that this is another cases. This is another cases the stent almost not deployed. Yes, so this is the stent we puncture in, and usually we will deploy in working channel and pull out. But at that time, I find a little strange. You can find out the stent did not open totally. You can see it's just only like a straight one and not full. We are very worried about the stent go inside a small bowel or peritoneum. So at that time, I think initially we press the guide wire to avoid the stent. And then we try to use some, but you can see if you just waiting, the stent will slightly open. So if you just use in the working channel deployment, you should be very careful because sometimes the quality of stent we cannot images. Or another one we just want to show in. If you want, because we use the oral entry tube to inject the contrast, right? So after your stent removed, you should be very careful because this case we just puncture through the oral entry tube, the double pigtail. We just pump through and deploy the stent. So until now it's very smoothly, but you can see that our oral entry tube is circularly with your heart issues. So now we will under the floor and endoscope you together to remove your oral entry tube. So at that time we just insert the guide wire in the oral entry tube to let this stent become straight. You can see it becomes straight. Yes. So and then slightly withdraw your oral entry tube. So even that, so you should really be careful. Not just only put the stent is finished, even some details step you should be very very closely. I just only two cases limitation is that sometimes you can see you have an intermediate bar between your target bar and the stomach. I think for these cases, it's not suitable for USGJ. And another one is your target bar wall is very thickly. So at least I think also it's not suitable for USGE. So like this one. So at the end, I just want to share actually in Taiwan, we start perform USGE because Professor Tawi, in 2019, he have a left demonstration in Taiwan, and we are asked him to give us some suggestions for USGE, and he wrote this map. So we still keep this ones in our units. So until now, we did with our Taiwan USG group. So until now, just like Professor Wang mentions, we already did almost as 180 patients, and we have very good technique and clinical success rate and acceptable adverse event. I think the most I just want to mention, until now they have very good patency rate. Most cases, more than 50% can keep the scan patency rate more than 600 days. So it's my take-home message. I think now, although now USGE is off-label use, but I think this idea is quite good, and more data will become to demonstrate this procedure is safe and very good long-term efficacy. So for my personal experience, if you don't have the dual balloon occluded device, maybe the red puncture with wise technique will suggest. But just like I mentioned, this design is not totally perfect. So maybe in the future we just need to correct some idea and some design, and of course they still have some limitations. Okay, so thank you for your kind attention.
Sorry, now time is a little behind, so cannot any question. If any question, just type in the online, and Patco will answer. And for the on-site, you can ask him in the coffee break. Okay. Okay. Thanks, Dr. Guo. And we will maybe not more than 10 minutes. Please come back on 10:45. Okay. Coffee break. I have prepared very famous Taiwan pineapple cake. Please, in Taiwan. Please. Oh, thank you very much. Thank you very much.
翻了一页说10:45，
开始对。
我看到了。
We have a seat. Okay. We will start the continuing our program. The next speaker is Professor Chen from Tsinghua University Hospital, Taipei. He will talk on the. Of course, he is a co-director of this program, and he will talk on the US guided external injection for pancreatic tumor. Let's welcome Professor Chen.
Kind introduction, Professor Awi and our dear colleagues and our distinguished guests. So today, my topic is about the injection therapy, US guided. My talk is focused on two parts. One is the pancreatic neuroendocrine tumor, and if we have another time, I want to talk about the left lobe or caudate lobe HCC treatment by the external injection via the US guided. It cannot be overemphasized that the only way to treat the PNET is the surgery. But some condition into situation, if patient cannot receive surgery, so our endoscopist can give some help for these patients. So for the small localized PNET, from the guideline, yes, the ENET, the NCCN, mostly is wash and wet policy. But sometimes on the rare condition, it may be turned to wet and pray because we cannot pitch it anymore. So if you want to receive treatment after the surgery, so we have the minimal invasive. You can use the enucleation. If you use the endoscope, we can use the thumb injection or the RFA. So the radio frequency treatment operation will introduce Professor So. Next. So our digestive endoscopy Taiwan Society, we have the recommendation statement about which kind of the tumor is suitable for endoscopy treatment. So include three parameters. One is is it functional or non-functional. Another is size, and the other is the grading. So it must be function. Will be have the better the symptom control, and grading is confined to the G1 or G2, and the size cannot no more than 2 centimeters. And of course, it cannot be like the lymph or the distal metastasis. Who is candidate for US ITP treatment? So our policy is for the post-operative recurrence, the pro-surgical candidate, refusal surgery, or the multiple comorbidity. So this patient will be rejected or cannot accept by the surgeon or anesthesist. So we can do this patient. So other than is the functional PNET, unwilling to receive the surgery, and the other is the ML1 patient with multiple functional or non-functional tumors. So this patient we can do the endoscopy treatment. Next. So this is the first report of the thermal injection for the PNET from the US literature from the 2006. So this is a linoma, and we inject the totally 8 millimeter at 95% in one session. Next. So since the 2006 until now, there are several papers, and the most two important papers from the Professor Shou's group. This 2015. They include the 11 patients, and there are 14 tumors. So next. So there's two insulinoma, and the other is non-symptomatic. So the totally symptom response rate is 100%, and local complete rate is 61. So this data is similar than our data. And the other one is 3 years later. They include 33 patients and 40 tumors. So among their patients, there's only one is the insulinoma. The other are the functional PNET. So they use in this paper they use the lipiodol mix injected to ablate this tumor. Maybe you can see if the tumor is viable or not by the image study. So their result is the tumor completion response rate. The ablation rate, 2 sessions is about 60%, the same as the former one. And the adverse event is only 2.3% adverse event. And the diagnostic concordance is 86. And there, the tumor size and the Ki67, the tumor differentiation is also declined, very remarkable. So from 2006 until now, so there's published English literature. So you can see from these papers, there's only case series. So there's no randomized prospective study because the endoscope treatment for PNET is not the standard treatment. It's just for the some patient. So from this data, we can see the success rate for the functional PNET is about the 95%, and non-functional is 60% also. So the adverse event is 20%. It's about the fever, abdominal pain, hepatitis, etc. Next. So how do I perform in our unit to do the US-guided thermal injection for the small localized PNET? First, you pick up the patient. The tumor size is small, and their grading is G1 or G2, and they refuse or unfit for surgery. And then we use the 1 millimeter syringe, and under the US guided, we inject to the tumor. And the needle chosen is 22 or 25 single hole. Is not use the FNB needle. We use the FNA needle because there's more sharper and then can treat the target easily. And every time we inject, the amount is adequate, is 0.1 milliliter. And then to see the target is revealed the hyperechoic brush. Then we can make sure your ethanol is within the tumor. And then we will keep this the amount of the ethanol within the tumor. The needle will, must be kept at least for 1 minute, because it will prevent the ethanol, extravasation from the tumor. Next. So we from the distal part and to proximal part, and gradually push the small adequate of the ethanol. Next. We can use the fanning technique to make sure you can the alcohol can spread all over the tumor, and maybe can 2 more 0.02 centimeter will cover the whole tumor. Next. So this is the video show the injection technique. So we use the 22 FMA needle and to put the button of the tumor and inject. And so we use the fanning technique to inject from the distal and pull back the needle gradually and then inject the So recently we can use the the contrast agent to make sure if the tumor is operated totally or not. So some technical issue should be discussed. One is the ethanol concentration. So you can see the diagram. The higher concentration will make the good effect. So there is the concentration dependent tissue necrosis from this study. Next. So how about the amount? So we can give the larger amount. We have the better effect to make the tumor necrosis. So how can we do calculate the injection volume? One is from the sonographic 3-dimensional analysis, and the other one is very simple. You can just calibrate the tumor, the long axis and the short axis, and then the summation divided by 2. And you can have the estimate to have the injection amount. But there is some discrepancy from your estimate and your actually inject volume. Yes. So you must until the tumor is totally hybric brush, and then you will start finish the procedure. And the other key point is the needle. So as you see, the needle, there is some mark made by the laser. It can be visible on the ultrasound, but the tip of the needle, there's no mark. So it cannot be seen on the ultrasound. So you must pay attention. So your needle should not to expand extra to the margin. You must be within the tumor. Your needle must be and must keep some maybe 5 millimeter away from the margin of the distal part of the tumor. Otherwise, you can inject outside the tumor. And if you near the vessel, you will be very dangerous and cause some adverse event. The risk of pancreatitis from the literature, you can find if the volume or more than 3.5, you will be at the risk of pancreatitis. And so, from the former 2 studies, the complication rate is about 10 to 20%. But if you have the larger cases, maybe the complication will decrease. So the follow-up protocol is maybe after the procedure, maybe 1 month, and then 3 months, 6 months. And the modality, you can use the contrast enhanced because the peanut is a hypervascular. You always use the counter-enhanced CT or MRI, we have the correct interpretation. If you suspicious they have the recurrent or not, there is still usually you can perform the USFME to confirm. So this is our data on hospital and Professor Wang. So we totally have 39 patients, and there is 25 is functional and 14 is non-functional, and all except the one to have the pathological diagnosis. So our result is the complication response overall is about 50%, and it is effective for the single one, and the multiple is mostly belong to the MEO1. So MEO1 is seems to not easy to operate, and for the insulinoma, single insulinoma is very easy to operate, but the multiple insulinoma is cannot is difficult to operate completely. So the brief summary is US ethanol injection is safe and effective treatment for those patients unfit for surgery, or they have post-operative recurrence. So for the single insulinoma, there is about 19% successful rate, and for non-functional PNET is about 60%. So we have still to okay. Next, we can see some cases of the HCC treated. Some video next. So if the tumor is located at the level of the carpet lobe, you can use the US guide, because if you from the traditional percutaneous route, the route will be very long. Yeah, but you from the endoscopy route, it will be very easy. So we have cases. So there is two important papers next to describe the US guided intervention for the liver tumor, especially at the level of the carpet lobe. So this case is our 64-year-old man. So his tumor is located at the carpet lobe. He refused surgery. So we initially we treat him with the TAE, but the effect is not so good. So we use the ethanol injection. So the same, just as the PNET. So we use the fine needle, the FNA needle, to inject with the 99 percentage ethanol to ablate this tumor. So and the technique is almost the same, and the volume expectation to inject is use the equation of the spherical. So estimate that we maybe use 4 to 5 milliliter to ablate the tumor. So 2 months later, so you can see the contrast enhanced CT. There is no more tumor stain, and the patient is until right now there is no recurrence. And the other is located at the right lobe, the segment 6. Because she is very nervous, so it cannot receive the percutaneous conventional route to ablate the tumor. So we use the technique just as the HDS at the BOP to endoscope to treat his tumor. So you can see the tumor is located in the segment 6 next. So we the transducer is put on the bulb of the duodenum, and we to locate the tumor. And then we use the same session to perform the US-guided liver tumor biopsy, and then we inject the iodine. Because if you have the same session, the iodine may be extravasated from the injection needle. You have done the biopsy with the root. So maybe you will change the puncture direction and use the as you can to use the fanning technique to abrade the whole tumor. Next. So this is the basal cell carcinoma recurrence. So 2 months later, it also has the no tumor stain. Next. And this is the colorectal cancer patient with liver metastasis. Because the chemotherapy is not so effective, so the oncologist requests us to do the local treatment for this patient. Yes. Initially, the first step is to confirm these 2 tumors is the colorectal metastasis. So we perform the FNB, and so we divided 2 sessions. Initially, we perform the biopsy, and then we perform the RFA. So we use the STARMED, US-guided RFA to abrade these 2 tumors. Next. So we use the 1 centimeter needle and 19 gauge, the combo setting, and use the 30 watts energy to deliver. So these 2 tumors we abrade in 1 session, and this is the segment 3. So the energy delivered to the pancreatic tumor and to the liver tumor, in my opinion, they were different mode because we perform the percutaneous RFA. The procedure time is about 10 to 15 minutes to abrade HCC. And also, although this is not the HCC, but the background is the liver tissue, so it's not the same as the pancreatic tissue. So this case we abrade about 10 minutes. 10 minutes. We have maybe more 15 session to abrade the tumor. The interval is 30 to 30 seconds. Thanks. Because I think time is limited, so we jump to the final result. Because the follow-up CT, radiologists consider there's viable tumor. So we perform the ethanol injection for these 2 tumors. So, and finally, we have the good result. So the patient is still uneventful to follow up at the oncologist department. So ladies and gentlemen, I give my conclusion. Yes. So US-guided alcohol injection is, I think, is safe and less invasive procedure to do for this. I thought the special patient, the small group patient, to break their tumors, and the complication rate is very low, and so everyone, I think you can try this technique to treat your patient. Thank you very much.
Thanks, Dr. Chen. Is there any question for his talk? Question about the echo injection? Okay, please.
Thank you, Master, for your explanation. Also, so what we need to use some pre-medication like foil or NSAID to prevent hepatitis when we performing the alcohol injection.
For some giving the some precaution procedure. So I will give the maybe safe manual suppository, and then all will give in lactate infusion for the procedure during the procedure.
Other question?
Yeah. Okay, please. You first.
I want to ask about the HCC,
HCC.
alcohol versus the RFA. How do you choose? Because with the RFA, you get the field destruction of the abnormal HCC environment, whereas you don't get such effect with the alcohol. So how do you choose to? And RFA is very treatment.
Yes, until now, I don't have survey any paper to describe the RFA for endoscopic US guided RFA for the HCC. So my opinion, I have inquired the company, the Starman. So I inquired the manager about the mode of the treatment. So he told me that there are 4 modes of this machine, the combo. So one is for the pancreatic, the PNAT. There is the low energy and the short duration. But he told me that you can change the mode to the continuous mode. So you can deliver longer time and larger energy to a private tumor. Yeah, so it's proprietary. I think I avoid the HCC. I use the longer time, maybe 10 minutes. So not short interval for the period. It's totally different.
I see some of the HCC is quite deep-seated. When we do the operation, when we do surgery for ablation, when we pull the needle out, we also burn the needle trap. Do you do that when you do that?
Oh, you mean maybe the seeding or?
Yeah, you burn the needle trap.
No, I don't perform the burn the needle trap.
So for HCC, I also make by IFA. My setting is 50. For HCC, I not use 31, and I use a considered mode. And when I burn, the metal is really good bubble, and then I slowly pull back, really slowly burn again. And this is the second one we give more detail. Things for HCC is the second one, and go to their family for us, to use that.
For the PNET before external injection, do you put the PD stent? And another question is how to choose between the RFA and external injection for PNET. Which one is better? Or how to decide the tumor location? How to decide?
Okay, thank you for your question. From our previous meeting, the lecture by Professor So. So the P stand, because you will to see our image, because there is three-dimensional structure, so we cannot very accurately to calculate, to measure the tumor, the distance between the distance between the tumor and the P dot. So if maybe we have the rule of 5, initially designed by Professor So and Professor Wang. It's maybe 5 millimeter. Yeah, if you less than, you can better put the P stent to protect the P dot. But I think it's very difficult to accurately to see if the tumor is so close to the P dot. And choose the ethanol or the RFA because until there is no randomized control trial to either the RFA or the ethanol to PNET. the patient, the number is so small. And my unit, and maybe the head or neck portion, I manipulate the RFA catheter is difficult because the 19 gauge. So I will prefer use implementation because in ethanol, 99% percentage is available in Taiwan. And for the body or the tail, I can use the RFA. And the other factor is if the tumor is small or large. If the tumor is maybe larger than 1 centimeter, maybe I will choose RFA.
I think maybe after the RFA section by Dong also, he is the one who can comment which is better, okay? And about the standing, I think the echo injection for the small one. Previous we have rule of 5, but nowadays I think 2 millimeter. Sometimes difficult. Even the tumor always near less than 5 millimeter to the pancreatic duct. Our feeling is for small tumor, even the echo injection, because the amount is very small. Even inject to the pancreatic duct, it's not nothing happens. So nowadays, if you inject just a little, I don't think the standing is needed. But prophylaxis is better if you afraid about the pancreatitis. Okay, time is limited. We thank Professor. And finally, Professor Dong So arrived. Sorry. So we invited Professor Chen to in charge of Professor Dong So's speech.
I make a brief introduction to Professor So because it's so famous. Professor So now is the chairman of the internal medicine of the Asan University Hospital, and also the professor of the Asan University. And he is the chairman of the KPBA, the Korean Video Pancreatic Association, and also the chairman of the WISE, WEO, the education course. So today he will give us the lecture about the US guided RFA. Let's welcome Professor So.
PD.
I'm sorry, the first topic is PD and then RFA.
First of all, it's my real pleasure to join this course. I'm very sorry causing some fuss because of the delay on my flight, and yesterday I missed my flight. The topic assigned to me is US guided PD, pancreatic brain imaging. When we say US guided pancreatic intervention, the basic backbone is actually US guided pseudocystic drainage. It started very long time ago, and it involves a lot of skills, delineation of the lesion by US, linear US, and locate the target on ideal position, and doing puncture, and then insert guide wire, and the trap dilation, and the insertion of stent. Those are steps required for US guide various interventions. So with the modification of this technique, we are using US guided pancreatic drainage. Is is my last one. The one I gave this on my slide. This is also this one. Actually, when you look at the history, use-guided pancreatic gastrostomy started more than 20 years ago, 2002, by Jack De Vera and Mark Giovannini. They used this technique for chronic pancreatitis case. So they illustrated like this, and for the dilated main PD, they used 19-gauge needle and puncture and insert guide wire, and then with diathermic device, they dilated the trap and inserted plastic stent. This basic step is still we are using the same steps for use-guided intervention. There are other intervention which is use-guided rendezvous, and this was reported after use-guided epidural stenting. 2 years later, Malady group actually reported biliary rendezvous and pancreatic rendezvous. So these techniques were reported a long time ago. It is making very slow progress when you think about 20-year period. But I am still thinking it needs to be improved further. So nowadays we are using 3 different types of intervention: pseudocyst drainage, and with this modification, rendezvous or stenting. Use-guided PD is indicated generally chronic pancreatitis with severe obstruction stenosis. Sometimes it is benign stricture, or sometimes it is because of impacted stones. Difficult to overcome this stenosis. Then we can use this technique, or necrotizing pancreatitis, pancreatic duct disruption, or isolated feeder. Or in case of previous operation, pancreatic jejunostomy site stricture can be approached by this technique. These are steps of ESPD, the common procedure and the rendezvous and the stenting. Common procedure means common procedure with pseudocyst drainage. It involves targeting of the lesion and using needle, we can do puncture and guide wire insertion. For this procedure, we have various types of needles. We have luxury, nowadays we have luxury. When we first started the procedure, the needles are quite limited. We can classify 2 different types of needles based on the size of the needle, 19 gauge or 22 gauge needle. 19 gauge is, I think, most commonly used needle, but it is difficult to puncture the pancreas, especially when fibrotic pancreas, chronic pancreatitis cases. The parenchyma is very hard, so 19 gauge is difficult to puncture, but once puncture is done, the guide wire insertion part is easier, and we can use O25 or O35 relatively steep guide wire, and then subsequent procedure becomes easier. But we can also use 22 gauge needle. It is easy to puncture, but we can only use O35 or O21, O15 or O21 inch, very thin guide wire, so it's a little bit pliable, not enough stiffness, and fluoroscopically sometimes difficult to see. These are examples of guide wires. My most favorite one was 0.5 inch PG guide wire. Thickness is 0.5, thinner than 0.35, but stiffness is similar to 0.35. There are various types of guide wires. Through 19 gauge needle, we can use 0.5 or 0.35. Various guide wires available from various companies. And with 22 gauge needle, you can use 015 wire or 21 guide wire. Some groups are using thermo wire very much. Then we can go to rendezvous procedure. Rendezvous means it's similar to biliary rendezvous, but when it goes to the pancreatic rendezvous, it becomes a little more difficult because pedal diameter is thinner than biliary tree. So on the ES, we can puncture the main duct, usually dilated main duct, and insert guide wire through the stricture. And then if the guide wire goes to the ampullary area and the duodenum, then insert guide wire deeply into the duodenum, and then remove the appendoscope and insert regular duodenoscope, and grab the guide wire through the instrumental channel and go into the pancreatic duct. Or we can insert guide wire alongside of previously inserted guide wire. This is in normal anatomy cases, but this technique also can be used for altered anatomy. Like this case, this patient received the pancreatic jejunostomy if the stricture site develops at the anastomosis area, and we can insert guide wire through ES guidance, and you can use single balloon or double balloon enteroscope to get an access to this area, and you can do rendezvous procedure. Rendezvous is similar to ERCP procedure once guide wire is inserted, but US guided PD is purely on the US guidance. After guide wire insertion, it involves dilation of the tract and the stent insertion. And in some cases, we need to do stent revision after some period of time. So stent exchange is necessary. For the dilation, we have various types of mechanical or quarterly dilator. These are mechanical dilators, so surrender dilator, or sometimes you can use Fuji balloon dilation. Or for quarterly dilation, you can use cystotome or microknife. Nowadays, microknife is not frequently used, but historically, it was the first device we used for this procedure. And there are two types of stents which can be inserted into the PD: plastic stent or metal stent. But generally, plastic stent is commonly used, and plastic stent was the original one when we started USPD. It is easier and less traumatic when we try to insert a stent, and lower risk of adverse event, and easy to remove, even though the stent has long period of endurance, more than 6 months or 1 year. But plastic stent can be removed easily. But there is some side holes. There are some doctors argue that there is a risk of pancreatic juice leakage. But in real practice, not much pancreatic juice leakage happens. So this Idoi group designed a new type of stent specifically for ESPD, relatively steep shot. The side hole is not in the middle. Can you see the cursor? Cursor is not in the middle. And the side hole is only at the distal and the proximal end, and there is a pigtail curve at the proximal end side to prevent migration of these stents. This is EUS at the time of EUS guided PD. When I first tried this one was more than 15 years ago. The pedal is not very much dilated compared to the CBD diameter, very small diameter. But I made a puncture using 19-gauge needle and tried to inject contrast. So we can see pancreatogram, but the angle is perpendicular to the pedal, and the scope is very straight. In this position, the scope is quite unstable. If you push something inside the pedal, then scope frequently bounce backwards, and So difficult, the guide wire passage was difficult. So I recommend to use this position. The scope shaft should embrace the pancreatic parenchyma or pedal, and the frontal side of echo endoscope need to face the duct running direction with this direction. With this one, if you see this video, because of previous contrast injection, the pedal was dilated more. Then I did the second function with a different angle, and the needle was overshooting like this, and then reject a little bit, and then inject contrast again, and try to look at the pancreatogram. Now you can see the pancreatogram here, and the guide wire insertion through this needle was quite easy. And after the insertion of the guide wire, we remove the needle. But after this, we need to dilate the track. As I mentioned when we first started this procedure, in Korea there was no available cystotome, so we used microknife, needle-like for the dilation. But needle-like tip is very thin, so the cauterization area is very narrow. So some degree of mechanical force should be exerted, and the tip side should be cauterized. And combining these two forces, we can do dilation. But the guide wire direction and the needle-like microknife needle direction can be different. It should be coaxial. Otherwise, you can actually burn in different areas. So the angle is very important. Finally, I was successful. Pushed the microknife inside, so you can see the tip of microknife went inside, deep inside the pancreatic duct, and then we can remove the microknife and insert the plastic stent like this. But this was quite traumatic, so there is some minor bleeding around the puncture site and the dilation site area. But successfully, the stent, plastic stent was inserted through the dilated tract. But if you see the gastric cavity, there is some bleeding and the gastric juice mixed. So this is final view of stent deployment. After this, we tried this technique to several different cases. This is chronic pancreatitis case. Calcified stones are obstructing the main pancreatic duct, so we tried ERCP first, but upstream duct is markedly dilated. ERCP failed because of the impacted stone. ESWL was done, but again, repeat ERCP failed. So we directly targeted NPD on the US, and then inject contrast. We can get the pancreatogram. It is not, there is no connection to the head area, completely blocked. So we dilated the tract. In this case, we can, for the dilation during this period, we used microknife or hurricane balloon or Sohendra stent retriever, not cystotome. And it dilated this tract and inserted plastic stent. Then the dilated P-duct showed resolution. After some period of time, the stent actually occurred. Mostly after 6 months, the stent, inner side of the stent shows clogging. So in that case, we need to do revision of the stent. For the revision, guide wire insertion is a critical step. We can insert guide wire through the previously inserted stent, but most of the time stent is blocked. And also, even though it is patent, the guide wire insertion through the stent is very difficult because of respiration and heartbeat. The stent tip is constantly moving. So I prefer to use guide wire insertion alongside of previously inserted stent. This video shows this is previously inserted stent. This is puncture site. For the guide wire insertion, tapered tip catheter was used. 5/3 catheter. And then inside the catheter, we inserted guide wire. The stent is already showed clogging. Inside there is no lumen. So using catheter, we are trying to insert guide wire. Generally, 3 to 6 months later, the puncture tract is well maturated. What I mean is the tract between the gastric wall and the pancreatic parenchyma. During the guide wire insertion, sometimes guide wire goes into the peritoneal cavity, not to the pancreas. So the axis control is very, very important. And the coordination between the endoscopist and the assistant is very important. Otherwise, you can make a hole in between these two structures, and further insertion makes the hole bigger. So subsequent procedure becomes difficult. After successful guide wire insertion, we can remove the stent by rectus forceps, and over the guide wire we can insert a plastic stent again. This step is called revision. And also this technique can be used for pancreatic or jejunostomy site stricture. This patient received pancreas head resection because of cancer, but PJ site showed stricture. So for that, we inserted the echo endoscope like this. Again, you can see the embracing shape of the echo endoscope here, and the face, frontal face is facing the PDUC direction, and after puncture, inserted the guide wire, and over the guide wire, initially we inserted the catheter over there, and then we used the Sohendra stent retriever. By drilling, we made a hole into the jejunal loop, and then we inserted the plastic stent like this. This technique can be useful for obstructed PJ anastomosis site. In some groups, they also used balloons. If there is stone in the main pancreatic duct, they use balloons and push the stone away from the MPD into the jejunal loop. So they did stone removal procedure also. I mentioned the plastic stent, but our group was probably one of the pioneer group who used fully covered metal stent into the pancreatic duct. So my colleague Tohenbach actually did use this fully covered metal stent for US guided pancreatic duct drainage. At initial study, they showed it is technically feasible, and the stent migration, clogging, pancreatic sepsis induced the structure was not that severe. So our group used this metal stent for USPD. The theoretical benefit of metal stent, it can improve the pancreatic drainage because of a larger diameter, and decrease the risk of stent clogging and lower patency. And the revision is also not that difficult. But there is still concerns of fully covered metal stent migration or blockage of the side branch or MPD. That was the concern. This is the video showing how we inserted fully covered metal stent into the pancreatic duct. The puncture step is the same. After puncture, we injected contrast, and MPD is here. There is structure, and the jejunal lobe is here. Guide wire insertion was tried but failed, so we decided to dilate the tract. On this one, we used hurricane balloon for the dilation, and then inserted fully covered metal stents. The fully covered metal stent is deployed now. This is distal, and now the proximal end is deployed. After deployment, we can see this type of figure. Fully covered metal stent with anti-migration flaps, proximal and distal end, so it does not easily migrate. With this one, we did long-term follow-up study. Among 25 patients, the long-term clinical success was achieved in 92%, but there were some late adverse events in 24 patients, which showed stent migration and followed by recurrent pancreatitis. And also, this stent can be used the pancreatic jejunal stricture, anastomosis stricture. Again, it showed relatively good stent patency and the clinical and technical success rate. Compared to plastic stent, metal stent shows longer stent patency. For benign strictures, stent patency was more than 1.5, median stent patency was more than 1.5 years. And for malignant lesions, median was 5 months. So it has advantage over plastic stent. But if the stent stays longer inside the human body, then there is some complications. This is stent fracture, and this longer stent actually shows more fractures, more percentage of fractures. We thought that this is because of the gastric acid corrosion and the shearing forces during intestinal peristalsis. But stent was still functioning. So compared to plastic stent, metal stent has the advantage of longer stent patency and less pancreatic leakage, but it is more expensive and the possible complication is side branch occlusion. If I summarize by these clinical studies, use guided PD is technically feasible and clinically quite useful. Except one extreme report, other reports says that the technical success rate is more than 60% and the clinical success rate is more than 76%. There is some complication, about 20%, which is bleeding, perforation, pancreatitis, or fluid collection, or stent occlusion or fracture. But these complications are not fatal or serious ones, so we can manage by endoscopically. So, use-guided pancreatic drainage is technically still challenging, but it can be very effective.